Good afternoon, everyone. Please settle down. May I request all the panelists as well as moderators to join in on stage. Our chair is already here. Good afternoon, everyone, and welcome to our final session for PMJ today on engaging with providers and strengthening public health infrastructure in ABPMJ. The primary objective of this session is to facilitate a comprehensive exploration of strategies that enhance healthcare provider engagement and fortify the public health infrastructure within ABPMJ framework. By addressing these vital aspects, we aspire to elevate the program's efficiency, accessibility, and overall impact. I would like to welcome the distinguished panel on stage, led by our chair, Ms. L.S. Changsan, an officer of the Indian Administrative Services, batch of 1994, Assam Meghalaya cadre. She's had an exemplary career in the services and currently serves as Additional Secretary and Mission Director for NHM within the Department of Health and Family Welfare. I would like to welcome our moderator for the evening, Mr. Amit Paliwal, with over 2 decades of extensive experience in health system strengthening, social health insurance, health communications with IEC, SBCC, and Human Resources for Health. He serves as the Program Director for GIC's Indo-German Program on Universal Health Coverage. I would like to now introduce our first panelist for today's session, Mr. Randeep D., an IS officer from the 2006 batch Karnataka cadre. He has been active in public service and currently serves as Commissioner for Health and Family Welfare Services and also holds a significant role of SMD for the ABPMJ scheme in Karnataka. Our next panelist for today is Dr. Krishna Reddy, a prominent figure in healthcare and medical innovation. He currently serves as Project Director at Access Health. Our next panelist for today is Mr. Aspi Minocher, who has had a remarkable career spanning over half a century. He has spent the last 30 years passionately dedicated to the field of medicine and currently serves as Development Director at the Shrimad Rajchandra Hospital and Research Center, Dharampur. Last but not the least, I would like to welcome to the panel Dr. P.R. Sodhani. Professor Sodhani has been a health economist and public health professor for more than 2 decades and currently serves as President IIHMR. I would now give the session to the moderator to start.
Thank you so much. I hope you guys can hear me. Yeah. Thank you so much for the introductions. And honestly, you know, as a moderator, it becomes my life very easy when I have such an illustrious panel with me because they have to do all the talking. It's great to see the audience here. I think the fact that we have a pretty packed hall itself is a clear indicator that this is a topic which matters a lot to people. When we are talking about healthcare, you know, we normally look at the beneficiary. That's the normal focus. You know, we are looking at the poor and vulnerable populations, trying to provide them the best quality healthcare. What we normally forget is that there's somebody who's responsible for providing the healthcare, and that's the provider. And as we all know, there are 2 kinds of providers, the private sector and the public sector. Now, what PMJ has done is that it's brought about a paradigm shift in the way we look at these providers, because now these providers are one of our important stakeholders, even the private sector providers. Earlier, you know, before PMJ and before RSPY, private sector healthcare providers were not really on the radar of the government. But now they are our very effective partners, and we have to look at how we have to, strengthen this relationship we have with them. So, and obviously, you know, the PMJ is also a paradigm shift when we look at the way our public healthcare sector systems are working, because we saw a major shift after the National Rural Health Mission and the National Health Mission came in. There was a lot of autonomy, financial autonomy given to the hospitals in the public sector. But PMJ has taken that a step further. So now all public hospitals who are doing their normal routine work get an additional amount of money through PMJ. But there are certain constraints because of which they at times are able to use it wonderfully well, like we will hear from our panelists today, and at times there are constraints. So the whole idea of this panel is to come out with some strategies as to do two things. One, how do we improve our engagement with the private sector, and how do we improve the functioning of our public health sector, so the quality of provision of services from them. And as you can see, we have Mr. Randeep, Shri Randeep ji, who's the commissioner, and he will be able to give us insights about the public sector thing. We have with us Mr. Minocher, Dr. Minocher, who's giving us the private sector perspective. We have Dr. Reddy, who will bring us the whole development assistance and the whole technical assistance, technical cooperation perspective. And we have Dr. Sodhani, who's one of the most illustrious names in academics and public health capacity building and research. So I think it's a panel which kind of encompasses everything. We are looking at the private sector, the public sector, the technical assistance, the academics, the capacity building. So with that, I would like to just hand it over to our chairperson. Ma'am, would you like to just set the tone, please?
Thank you very much. A very good afternoon to all of you. The moderator of today's session, Mr. Amit Paliwal, and esteemed panelists with me on the dais, and all the members of the audience. Arogya Manthan, this has been the theme, the core word that's been echoing over the last 2 days from yesterday. And under the Pradhan Mantri Jan Arogya Yojana, a lot of discussions, deliberations have been coming up, and today we are in the final session, and I'm really delighted to be here with you all. Mr. Paliwal has just laid out the background for today's deliberations on engaging with providers and strengthening public health infrastructure under PMJAY. I don't need to go much into the background of PMJAY. I think everyone would be, in the audience, would be quite familiar with the national health policy and the recommendations to move towards universal health coverage, and how in that process we rope in the existing public hospital network and also the public health service providers. And it's really noteworthy to see that over 26,000 hospitals have been empaneled under the PMJAY, and we've had crores of patients who have availed of the services under PMJAY, and similarly, huge crores of cards have been created, beneficiaries have been created under the PMJAY. But as rightly mentioned by the moderator, that a lot has been looked at from the beneficiaries' angle. We need to look at the service providers' angle too. And that's where today's discussion becomes of great importance. You know, we have, right in the public health sector, starting from the very basic level of the sub-centers, we have over 1.6 lakh health and wellness centers. Then you have the primary health care centers, community health care centers, and district hospitals. So at the primary and secondary level, you have this huge network. Not to speak of the tertiary sector, which is there in the higher institutes of medical education, medical sciences, the hospitals with the medical colleges and the institutes of national importance, AIIMS as such. What we are trying to look at is, in the whole process of PMJAY, one exciting avenue has come up, and that is that the autonomy that has been brought out, that has been given to the institutions where all these healthcare services are being provided. Obviously, right now it's still the CHC and in few cases PHC level wherever inpatients are there. but the Rogi Kalyan Samiti has been able to get a lot of funding through the PMJAY, and that is largely helping it. It is meant to be helping the hospital or the health facility to generate, to take care of its own requirements. You know about the government funding system. We have the National Health Mission, of which currently I'm the mission director. And of course, there we have about 29,000 crore budget that we spend all over the country, all states and all health facilities. But that is a specific tied kind of fund. You have norms, you have framework, you have specific guidelines, components, activities, though a lot of flexibility has been brought in now. But at center level, when I say center, it can, whatever level of the health facility, that kind of autonomy it becomes sometimes very essential. There are certain areas in a particular location you might be having more requirement for some particular illness, for some kind of intervention, diagnostics or treatment, things like that. And in certain areas, it may not be same for all. So that is where the RKS, the funding under that, we need to see how best this can be utilized. We have, we'll be listening to some examples, some best case, the studies of the good work that have been done in some cases where the Rogi Kalyan Samitis, the RKS funds have been utilized imaginatively, innovatively by the RKS and the health facility in charge for the benefit of the people. In this way, there's a lot of incentivization, there's a lot of ownership and investment of the healthcare service providers themselves. It's always it's a two-way street actually when you look at healthcare, basic, and of course this multilateral also. But when you have a beneficiary, a patient who is requiring some kind of treatment intervention, and on the other side, unless you have a robust, strong healthcare provider service system, the arrangement is not going to work. So, under PMJAY, the authority, the National Health Authority has given guidelines and frameworks whereby this fund could be utilized. States have imaginatively, they have been using this in some active ways. In some areas, it needs a little more prodding, little more boosting would be required. But I think that this is the right time when we start considering and deliberating upon how we could strengthen our public health facilities on one hand and use these resources that are available. And at the same time, when it comes to the private health service providers, how best we can engage with them and try to involve more and more, especially in the urban areas. I can tell you for a fact that the National Urban Health Mission has not really been able to take off because simply that we have a lot of service providers in the urban areas. But under the PMJAY, they can be effectively roped in, and it doesn't have, in the urban areas, it doesn't have to be a replica or a model of what is working in the rural areas. And that is where especially we find that the private healthcare service providers, there's a lot of potential where the people could be benefited, out-of-pocket expenditure could be reduced. Here is a scheme, the one of a kind scheme in the whole world, the largest one where health assurance up to 5 lakh rupees per family is being given. It's an excellent scheme, and we just need to expand the reach and cutting across different stakeholders in this process. So looking forward to hear the panelists on this. Thank you.
Okay, great. Thank you so much, ma'am. I mean, it's great to hear your perspective on the complementarity between the National Health Mission and the Pradhan Mantri Jan Arogya Yojana, a perspective unfortunately I never saw, but it's great to see that you really identify that, especially in the urban space, there's a lot of complementarity. There's a lot which PMJ can do, which NHM could not do in spite of a lot of efforts from all of us. Now, when we are looking at the public health system, we all know that so a lot of my colleagues here who started working 15, 16 years ago, you would remember that when we used to go in the first PIP formulation phases, and we would introduce the concept of untied funds, it was like an alien landing on earth. Nobody understood what is untied, because nobody in the last 50 years had ever heard of untied funds. Now, after 16 years, people are a little familiar with untied funds, but still, I think the utilization of funds is a big challenge. And when we go across states, we see that states are still struggling with using this money. This money for which they've worked hard is lying in their accounts and being underutilized. Luckily, we have some very good practices from Karnataka. And Dr. Randeep, if you would allow us, could you please share us what are the policy initiatives and what are the innovative mechanisms that Karnataka as a state has adopted, which is kind of using the PMJ corpus lying in the RKS funds and using that to improve the quality of service provision from the public health infrastructure? Over to you.
Thank you, Amit, for those questions, and thank you to Additional Secretary Ma'am and Chair for setting in context the course of our discussion. I would like to answer my question in around three parts, because first, it's very important to set the context in terms of what ABRK, as we call it in Karnataka, the Ayushman Bharat and Arogya Karnataka, what it is all about, what state-specific initiatives the state took, what improvements did it bring about in the healthcare system landscape of the state, and finally the challenges ahead, because nothing is without challenges. We always have to improvise and improve. So the story started in March 2018, a few months before the Ayushman Bharat Pradhan Mantri Jan Arogya Yojana was actually launched. The state had its own state-specific health assurance scheme. Now this came out of the state health policy 2017. Around the same time, we had the national health policy also. Now, this talked about giving health assurance on family floater basis up to 2 lakhs. So when in the same year, about August 2018, when the Honorable Prime Minister announced the national scheme, the state hopped on board and said, why not have a happy merger? And the two schemes were merged, and that is why we call the scheme in Karnataka as the Ayushman Bharat Arogya Karnataka scheme. Now this has been a happy marriage till now, and we've been accessing both the central and the state funds. Overall, around 2942 public health institutions are empaneled, and we have private hospitals of around 530. We look to improve. Immediately getting into the state specific initiatives. Now, what is it that we had to put systems in place to ensure the funds are better utilized here? One, of course, every state would have a SHA. It goes without saying. Karnataka also has. It is on trust mode, and we have the Suvarna Arogya Suraksha Trust. But what Karnataka has done slightly different is, for better monitoring of the scheme, brought certain aspects under the Commissioner Health's office also, which means setting up what is known as the Ayushman Bharat Arogya Karnataka cell right under the Commissioner. This is primarily done to create and give more focus to the public healthcare institutions, as the Chair had pointed out, that while one part is, of course, the private engagement, let us not forget that this is a good opportunity for us to strengthen our public health infrastructure in the state and the country. So in that regard, we had set up this cell, and this cell oversees the empanelment process. This sees the IEC activities, convinces the citizens that why one should enroll for the ABRK scheme, generation of the cards, ensuring that each one has this assurance card with them. So this is something that we have done slightly differently, and this has helped joint reviews, having the Commissioner as well as the EDSAS, two IS officers kind of driving the whole program in the state, has seen with measurable success. Now, It is a truly universal health scheme in Karnataka, I would say, because we were probably one of the first states to also bring APL on board. We didn't stop saying that this scheme is applicable only to the below poverty line. We said that why not extend it to the APL also, but with a caveat that, of course, it's only up to 30% of the package rate, which means 1.5 lakhs. And we allowed co-payment, which means, what it actually means is if say, of course, I'm disqualified being an officer, but say if I was an APL beneficiary, I would go to a empaneled hospital, avail the services, and end up paying 70% from my pocket, and at least get these remaining portions. So that ensured this whole missing middle was covered, and the APL coverage, card coverage also ensured that better access was given. We also did a deemed empanelment of all public health institutions, saying that there is no separate empanel procedure. You are a public health institution, right from a PHC to a district hospital, you are deemed empaneled, which means that, like it or not, you'll have to implement the scheme when it comes to public health hospitals. We did one more thing. We ring-fenced certain procedures. We said that X number of procedures, which is basically 40 treatment packages, shall be given only at the public health centers. Simple procedures which MBBS doctors could do on the ground, which required a day or two of hospitalization, nothing more than that. So that ensured that right from PHCs, we had pre-auths being raised, pre-authorization requests being raised, claims being raised, payments being made. Another unique system of Karnataka, which has both its pros and cons, is the online referral system, which means unlike in other states, a person cannot directly go to a private hospital and say that I want to avail this service. Now, why did we do this? Not to restrict access to any private hospital, not to say that the outgo would be more to a private hospital. That was not the objective. The objective was to strengthen our public health infrastructure, ensure that people avail the basic services which are available in public health institutions, rather than just rushing to a corporate hospital. Let me also put a caveat that in case the facility was not available in the government hospital, then immediately an online referral slip was generated and given to a patient and said, here, go to any of the 513 private hospitals which are empaneled with us and get your treatment done. So that was also done. And I would also like to add that around 171 odd procedures, which are emergency procedures, trauma care related procedures, had no referral, which means you could just walk up to any of the private hospitals and get this done. So these are some of the unique features of ABPMJY, and to do credit of NHA and Government of India, they've allowed us to have this flexibilities to drive it as a state-specific kind of a scheme. So this has helped us innovate and kind of improve. Now, some of the major improvements that we have seen, yes, over the last 5 years, huge claim dispersals have happened. And the unique feature, I think this was also pointed out by you, ma'am, that what is the contribution, how much of the claims a public health hospital in Karnataka vis-a-vis a private health hospital gets. And when I look at the figures, it's very heartening, ma'am, that while private hospitals have claimed around 3,500 odd crores, that's about 52%. The public hospitals have claimed 3,200, which is about 48%. So we are neck to neck in Karnataka in terms of the public hospitals and the private hospitals giving care to the patients. Coming back to the whole point of this AVRK corpus which gets built up, the scheme allows for team incentives, the scheme allows for a corpus to be built at the hospital level. Ma'am was talking about the JSK Samitis. Now, these have become empowered now. We are seeing that they are no longer dependent on the state for supply of essential drugs, supply of some minor equipment, essential key HR which needs to be deployed, are all getting done now at the local level. They don't really send letters to Commissioner's office or write to the Secretary or request the public representatives. So the smaller issues are tackled at lower level now. Earlier they just used to have the user fee account. Now we have a huge corpus with them, ranging from anywhere between 10 crores to 1 crore, right at the district hospital, private CHCs, and even at the CHC level. So money is not an issue anymore. They have realized that in case they avail the scheme in the right manner, treat patients and claim the money is going to come back to them, because we have a turnaround time of close to 10 to 15 days in the state, be it for a private hospital or for a public hospital. Huge examples at the PHC, CHC. One of the success story, if I can see some students and researchers also here. I mean, if you are interested, try and understand how this has impacted at the grassroots level. We did a study, ma'am, of TB, how TB has been addressed through this. We did a 2-year analysis, and my colleagues shared this figure. They said that access to quality TB care and timely referral to higher hospitals was much better in these last 2 years. This translated into about 7.65 crores of treatment expenditure, which the Ayushman Bharat funded. 89% of this was in a higher facility, public healthcare facility, not necessarily a private facility. And mortality was less than 1%. So it's a classic case study of how a public health institution at both the PHC level and a higher facility have facilitated in ensuring the national goal of achieving TB elimination. It's an interesting study for people who want to see how this was achieved in Karnataka. The focus on infrastructure improvement has also been there now. With this money being plowed back in essential repairs, renovations, we have permitted for upgradation of district hospitals, taluk hospitals. We have money from NHM. I think the ECRP fund, ma'am, was well used by the state to put up ICUs in district hospitals, taluk hospitals. This again creates more beds, more facilities for patients to be referred under AVRK. And this again, in a cyclic manner, plows back the funds back into the public health facility. So I think tremendous progress, tremendous gains, and this has truly been beneficial for the state. Lastly, I'd like to conclude by saying the challenges, because nothing goes without challenges. We need to strategize and ensure there is standardization of services, because not all public hospitals, as you are aware, give equal quality of care. So now that we are providing to 3,500 odd facilities the Ayushman Bharat scheme, we need to ensure that there is standardization. We need to align our HR with IPHS standards, something which the ministry has been telling us repeatedly. That is a challenge, because again, their funds, resources, and state approvals need to be taken. The present low package rates, NHA has been pushing us to adopt the HBP 2022 package, which the state is in the process of considering. Maybe some kind of a support from Government of India also, in terms of proportionately enhancing their share, would prod the state to accept the new package rates. The coverage of the high cost and rare diseases, which presently we are not seeing part of this package. Why I say this is that for the SCST patients from the SESP TSP fund, the state has innovated a unique program for those diseases, because higher level cancers, rare diseases, people really don't know where to go. The private hospitals charge a bomb, and the public hospitals do not have these facilities. So we do have a scheme, and probably in the coming days, NHA and the ministry can look at involving this also as part of the package. The largest challenge remains, how do I push a private hospital to come on board? I think that is why we are all sitting here to discuss what better can be done, and probably from the audience you can also suggest if any such changes are there. So thank you for this opportunity, and I look to interact with the others on this panel. Thank you.
Thank you, Randeep. I mean, it was a beautiful demonstration on how a small tweak in the institutional structure and the setting up of the ABRK cell under the commissionerate kind of ensured that the three silos in a state, and sorry for using that word, but we have the SHA, we have the NHM, and we have the DG side. They were all kind of, and they all are very well-meaning institutions, but they kind of are myopic to their own areas generally. And by setting up this cell, you were able to kind of ensure that the visions were broadened for all three, and the kind of impact it had not only on the processes and the utilization of funds and the quality, but the clinical impact on the TB, as you mentioned. So this is a classic example of how a small tweak in the system can really bring about a cascade impact on the entire system, where the entire system can start functioning better and kind of start performing better and really providing good clinical quality care to the hospital. So I think he deserves a big round of applause. I think we all should really thank him. Great. With your permission, ma'am, I would like to invite Dr. Minocher next. Dr. Minocher is the director of one of the best performing hospitals private hospitals in Gujarat. And by best performing, we mean that their hospital, the Shrimad Rajchandra Hospital, is one of the hospital which kind of generates the maximum amount of claims and are benefiting the most from PMJ. What I want to understand from you, Mr. Minocher, is that, we all are trying to somehow improve the health-seeking behavior. In the government system, we are trying to improve the quality of our services. And as Randeep ji mentioned, right now, public hospitals are neck to neck with the private hospitals when it comes to, fighting for the caseload, if I may say. But I want to understand from you, because your hospital is serving the vulnerable and poor populations. What do you think is the impact of a scheme like PMJ on the health-seeking behavior of the vulnerable and poor populations? I think that's something we would all like to learn. And also we would like to learn how can we strengthen this relationship between private hospitals and the government in a manner that it's a win-win situation. So over to you, Mr. Minocher.
Thank you, Amit ji. I'll be happy to answer this question, keeping in view that it must remain focused and focused on the Ayushman Bharat PMJ. But before I proceed, I would like to take this opportunity to mention that we are deeply grateful to SHA Gujarat for the profound honor and privilege of nominating our hospital for this conference. And I would also like to extend our heartfelt gratitude to NHA for the gracious invitation to participate in this very significant, crucially significant session alongside distinguished fellow panelists. We are truly humbled. So, keeping in view the question that what is it, how do schemes such as the Ayushman Bharat scheme influence healthcare seeking behavior of the underprivileged tribal people? I would like to first start by mentioning that we are a 250-bedded hospital located in a place called Dharampur in the Valsad district in southern Gujarat. It is a totally tribal area surrounded by underprivileged tribal people from areas such as Dharampur and Kaprada, from the Dang district, and from even the neighboring Navsari district. And this is a very small, a very young hospital. It's hardly a year old. It was virtually inaugurated by Honorable Prime Minister on the 4th of August 2022. So it's less than a year, or just about more than a year old. But our journey in the field of healthcare began 18 years ago when we set up another small hospital in 2004, and then we shifted to this new hospital. We anticipated that this hospital would serve us for the next 5 years comfortably, but we have been taken completely by surprise, ma'am, that in the very first year we are already enjoying a bed occupancy of 180 to 200 people. And 10% of the beds only are reserved for the privileged. 90% of the beds are reserved for the underprivileged tribal people. And I'm very happy to inform you that of the patients admitted in a hospital, 85 to 90% are having they come with a valid AV card, Ayushman Bharat card. Now, as I mentioned, we were taken by surprise, and let us review what is it that happened which made the tribal people accept our new hospital so quickly. First and foremost, it is a hospital which offers a number of super specialty services like cardiology, open heart surgery, neurosurgery, plastic surgery, spine surgery, and even joint replacement. So now these tribal people, they don't have to travel. Formerly, we had to refer them to the Surat Civil Hospital, about 100 kilometers away. Now they don't need to go that far. They have these facilities locally available in their own area. So this is one factor which I think has played a very important role. And then, as mentioned by Mr. Randeep, there are always challenges that take place. Now, 6 months before this hospital was inaugurated, we became deeply concerned that would the tribal people accept this hospital? Now, why do I mention this? That when you look at this hospital from the outside, in the middle of nowhere in a tribal area, it looks massive. It is a 200,000 square foot of built-up area. It's got 3 blocks, each ground plus 4. And even if I say so myself, the facade is gorgeous. It looks palatial and magnificent. And we were concerned that the tribal people who would turn up at the hospital, would they get intimidated by this hospital and turn away from the gate itself? So when we anticipated this problem, and also once they came into the hospital, then would they get lost in this massive hospital? So we did 2 things, which I think has helped considerably. We invited approximately 200 village sarpanches of about 200 villages, in batches of 4, and showed them the hospital, made them aware that this hospital was built for the tribal people, give them a good lunch, looked after them very well, and spoke to them about the importance of the Ayushman Bharat card. That the best thing that they could do in the 6 months that the hospital was going to come up in is to ensure that every single person in the village had an Ayushman Bharat card. So this, I think, has played an important role, madam. And the next thing we did was, there are 2 major tribes in that area. One is the Dhoria Patels. That's the overwhelming majority. They speak a language called Dhoria. And then there is another tribe which speaks a language called Kukani, which is a hybrid of Marathi and Gujarati. So from both these tribes, we hired and employed young people, boys and girls, who were kind of at least standard 12 pass. Some of them were graduates. We give them intense training, not only on understanding about the hospital, but also on soft skills, on how to manage these patients, how to treat them like VIPs, take really good care of them. And this has also done wonders, because when these patients come in now, they are well looked after. There is a lot of hand-holding taking place, and they don't have to get lost. They are taken from, let's say, the registration desk to the consultant, to the doctor, and then to the OPD, to the diagnostic centers, blood tests, etc. So they're very well looked after. So I think that this has helped considerably in influencing the behavior. I'm using these words, influencing the behavior of these underprivileged tribal people. And lastly, I would like to mention that the strong, robust, and a very supportive public-private partnership model that exists in Gujarat. I speak from personal experience. For me, it's a great pleasure to visit Gandhinagar, as Mrs. Remya Mohan will testify, once a month. It's a great pleasure to go there because we enjoy a great relationship with them since 2007. And it has helped enormously that selected hospitals in the state of Gujarat have been authorized by the SHA Gujarat to actually issue Ayushman Bharat cards themselves. Like we also are able to issue these Ayushman Bharat cards in the hospital. And that makes a big difference. And then there is full support by an involvement of the SHA government to overcome different hurdles that we keep facing from time to time, where our staff approach them and they, regarding timely payments, delays in payments, or claims rejected on certain grounds that we don't agree with, or untenable queries raised by the TPA, and they are most supportive and they really help us out. And I know that they do that for other NGO hospitals too. And then very easy and supportive access from the highest echelons in the Department of Health in Gujarat. The doors are open and they give us an open ear and listen to us. And to me, this demonstrates the very efficient governance and administration adopted successfully by SHA Gujarat, and the keen desire, and I know they are passionate about this, to continually improve the scheme's reach and effectiveness in different ways, such as ensuring that even small private healthcare sectors remain engaged with the Ayushman Bharat scheme. So I hope this answers your question, Amitji, to some extent. Thank you.
Thank you, Mr. Minocher. I mean, I think the passion in your speech was clearly visible. I mean, I think he deserves a big round of applause. I mean, to me, what was startling is that, we normally, when we're talking about private sector, we have the Apollos and the Maxes and the Fortises in mind, and we don't think that these would be really catering to the vulnerable populations or really go the last mile. Like Mr. Minocher mentioned that, we normally think outreach is a function of the public health system to reach out to the community. But the way they reached out to the community, to the sarpanches, even catering to the linguistic preferences of the people, to ensure that when the patient comes to their facility, he feels at home. I think that is the connect which was there, and that passion was really visible in your speech, Mr. Minocher. So thanks a lot for that. Again, I think it was a good add-on or a supplement to what Mr. Randeep said, that you make an administrative tweak at the top and you kind of create this cell at the commissionerate. But it also depends on the behavior and the attitude and the outlook of that cell. And the way the SHA Gujarat, for example, has been kind of very welcoming of the public, or the private sector. For example, normally we used to be very close to the private sector. As people working in the government, we say, okay, our job is to stick ourselves to the government. We don't really reach out to the private sector providers. But this whole very facilitative, welcoming approach, I think that is also a very important factor, which is key to the success of private sector engagement. So thanks for bringing out those aspects. I would like to now move on to Dr. Sodhani. Dr. Sodhani, as you all know, is an esteemed academician and researcher. He is also the person who set up the Center for Health Economics at IIHMR Jaipur. What I want to understand from you, Dr. Sodhani, is what are the insights and strategies in your rich experience which the government can adopt to improve the infrastructure, the public health infrastructure across India? I mean, you've worked a lot across India. So what do you think? I mean, and this can be within PMJ, it can be beyond PMJ as well. But in your rich experience, what are the strategies that various governments have adopted to improve the public health infrastructure by using funds maybe from NHM or PMJ, so that we can kind of customize them and bring them onto the PMJ fold? Thank you.
Okay. Thank you, Amit. And first of all, I would like to give a big thanks and grateful to the NHA for inviting in such a very significant conference at the national level, and the fellow colleagues and also the participants' view are very, very important in such a gathering. Just responding to the Amit, I come from an academic institution. I am not running any hospital or not in a service delivery models. What we do, what are our products? Our products are knowledge product. We create knowledge or we sell the knowledge for the community welfare. What are the products at IIHMR University Jaipur? Naturally, our products must be useful to the government interventions. We do two major things in IIHMR University. As a postgraduate research university, we do research in the health systems. That is one of the fundamental area what we work in IIHMR. Conducting the health systems research, and second is training and capacity building. These are the two major areas where we are working since 1984. Since last 38 years, we are working in the health sector very closely with the Ministry of Health and Family Welfare, Government of India, various state governments, development partners, WHO, World Bank, and other UN agencies. As far as research is concerned, I would still feel that research gives new knowledge for the program management and policy planning. The research comes with the new ideas, new thoughts, and also they suggest the corrective actions in the ongoing programs. We do a lot of research in the health facility related, hospitals related. We also see the provider's perspective in providing healthcare services. We also do a lot of research in understanding the client's perspective in getting the healthcare services, and also the programmatic and policy planning related research. As far as capacity building is concerned or the training is concerned, we are usually involved in providing training programs to the people who are engaged in the health systems environment. These participants are come from national level or international level. We have catered the need of 40 plus countries globally as far as training and capacity buildings are concerned. And we provide trainings mainly in the area of leadership and management. And we feel that the health system's performance, it is not low due to the clinical failures. Mostly it is low to the management failures. Global literature suggests that if we improve our management practices in service delivery or even in the hospital environment, the efficiency of the hospital will increase definitely. Either we have not equipped hospital or we do not have equipped public health facilities, but that can be taken care if we invest in the human resources through capacity building program. India is among those countries where resource crunch is there for the health systems. And it is not today's problem. We have seen this problem since many years. And I think thanks to Government of India and thanks to Indian stakeholders that they are able to manage this health system in this financial crunch situation that have provided, these challenges have provided us a lot of opportunities to think widely and how to use the allocated resources wisely. We are working towards a lot of cost-effective interventions. As in higher education institutions, we provide a lot of support in conducting cost-effective interventions. And here I would like to urge to the Government of India that we should use our money appropriately, whatever money we have. But these interventions related studies, cost-effective intervention related studies should be promoted in India. As far as literature suggests that most of the developed countries, they are doing this type of studies on cost-effective, cost-benefit and all these things. But as far as low and middle income countries where resources are problematic, we are not engaged in such type of studies. If we promote such type of studies, I think in the public health systems environment, the cost consciousness will be enhanced. And the cost consciousness, that will definitely lead to improving the efficiency of the hospitals. Either it may be district hospital, community health centers, or even primary health centers. As far as training and capacity building programs are concerned, currently we are engaged in a very huge task, that is providing a leadership certification program to community health officers. We all know that when the IIHMR Bharat was launched, a new position has been created in the health system, that is community health officers. And it is a key link between the health systems and the community. To provide the leadership skills to the community health officers, we have trained around 1,300 community health officers in 13 states. And only the last date has been concluded. And almost all 1,300 community health officers have been now leadership certification programs cleared. It is a great initiative. And 13 state governments have nominated their candidates in this. I really admire the role of state governments that they have came forward for such type of training programs and capacity building program. Now there is a huge request from the various state governments that why not such trainings can be conducted at our institutions. Although we started this training in the COVID time, so it was the online edition. But the similar type of training can be conducted in person and physical ways. Similarly, as far as access, availability, financial problems, all these barriers are concerned, I still feel that we need to adopt the digital technologies. Now the era is of the digital technology, and most of the problems of the health systems can be tackled if we really apply the digital technology, and we can get through the barriers which are related to distance-related barriers, human resources related barriers, or even the infrastructure or equipment related problems. Most of the problems can be tackled through digital interventions, and Government of India has already taken a step towards this, is to set up the digital mission and working towards this area. At IIHMR University, we also feel that it is one of the emerging issue, and we have decided to open a new school, that is School of Digital Health, where we will provide the research support as well as training and capacity building support to government and other agencies in the area of digital health and healthcare analytics. Second point which I would like to emphasize, the research clearly emphasizes that in the health systems we are not able to use the data for decision making. We have a lot of data from district hospital to primary health centers to the tertiary care hospitals. Data are related to patients, disease burden, lot of data are available. But are we utilizing this data for decision making? Still the answer is not very satisfactory. I think there is a huge requirement for capacity building of the staff so that they can utilize the data properly and use the data for decision making, and the decision making is, if it is sharpened, naturally we can utilize our resources optimally and more useful. Thank you so much for giving this opportunity.
Thank you. Thank you.
Thank you, Dr. Sodhani. I mean, honestly, you were sounding more like a practitioner than an academician, which I think goes to your credit. The kind of the connect you have with the field was clearly visible in your impassionate remarks. I mean, very often, we feel that hospital can only be improved like within the hospital, but we tend to forget that there's a huge element of capacity building which goes into the whole thing. And very often, we look at hospitals as centers of clinical excellence without realizing that there has to be a lot of managerial excellence there as well. Because if the management is not really good, the clinicians will not be able to perform. So the fact that there is a vacuum very often in a lot of these private and public hospitals in terms of the management capacity, I think that was very well brought out. Another very, I think, interesting insight was that we normally attribute leadership to senior positions. Normally we would say leadership is right there, Modi ji and the levels of that kind. But we forget that leadership is at every level. So, I mean, having had trained 1,300 community health officers clearly shows that, you can build leadership even at that level. So those are certain very beautiful insights, and these all, I think, contribute very effectively to improving the efficiency of our public health and private health systems. So thank you for highlighting those very important aspects, Dr. Sodhani. I think he deserves a good round of applause from us. And finally, I have to come to my most esteemed partner, I would say, Dr. Reddy. Dr. Reddy, as I'm sure you all know, has decades of experience in public health. He is the head of Access Health International Asia, and he's also set up the Global Learning Collaborative for Health Systems Research and Resilience. So with his rich experience in public health and focus on research and on resilience and collaboratives, I would like to learn from you, Dr. Reddy, in your experience, what have been those key initiatives which you think have contributed to strengthening the healthcare systems and provider engagement? And also, if you could just maybe touch upon what Dr. Sodhani brought up, the evidence-based policy formulation. If you could kind of share your experience on how these can be utilized to strengthen public and private healthcare systems, that will be very good for us.
Thanks, Amit. One is, I would like to give the perspectives, one as a Access Health, from a health systems research perspective, or the technical support perspective, but also as a private provider perspective. I happen to be the co-founder of Care Group of Hospitals, so a chain of 16 hospitals. I also run the trust hospitals, so different perspectives as a private provider. And as a health systems, whatever insights that Access Health could get in the last 15 years. In fact, the first insights that came from Arogya Shri in Andhra Pradesh. That was the first program that happened in Andhra Pradesh. We studied both what impact was on the beneficiaries, what was the behavior of the providers, and what is the impact on the out-of-pocket expenses. And the experience we have been gaining thanks to the support of the UP state authority in giving us the opportunity to actually take the journey right from the inception, from 2018 onwards. And that rich experience of implementation research. That means when you're implementing a policy, it has to be iterative steps. I mean, you implement, study it, then take the next step. I mean, so that was a rich experience in terms of what needs to be done. Commenting on the engagement of the providers. In fact, I want to differentiate payer and provider. NHA and SHA is the payer. The public hospital is a provider. So it's client response. I think that differentiation, the government should differentiate as a payer, SHA, is it demanding from the public provider the quality that the beneficiary requires. I mean, that is exactly the strategic purchasing. You apply the same strategic purchasing role both to the private provider as well as to the public provider. Don't differentiate. But from a strategic perspective, as a stated objective of PMJ, that it has to be selective purchasing. That's what Dr. Shri Randeep has mentioned, that Karnataka is adopting a selective purchasing. That means as much as possible, you purchase from the public provider. And what public provider cannot provide, then you purchase from the private provider. The third aspect, I mean, irrespective of who is providing, if everybody realizes that are we meeting the needs of the beneficiaries? When we say needs of the beneficiaries, when they need it, where they need it, how they need it. Suppose there are time-sensitive emergencies like heart attack, I'm a cardiologist, or like a brain stroke, or a septic shock, or a polytrauma. These are time-sensitive. That means if the beneficiary cannot reach an appropriate intensive care facility within 60 minutes, the chance of death increases by 10% for every minute. So if you are really taking care of the beneficiaries, are we really addressing this health need in all its aspects? So I think this has to be kept in the perspective when we engage providers, both private providers and the public providers. From the public providers' perspective, I think the experience in the UP also was the teaching hospitals which were reluctant to, say, get empaneled or entertain PMJ patients. When you start creating awareness, what is the value that you will have by accepting PMJ patients? See, you have a fixed line item budget, but now you have demand side budget in terms of the top-up budget. So there is a dual financing of the provider system. I mean, I think that's where in the initial Arogya study, I know personally the teaching hospitals, both Gandhi Medical College and Usmania Medical College, the doctors who were working from 10 to 1, when they started incentivizing the entire team, right from ward boys to the consultants, they started working from 8 o'clock to 8 o'clock. Just a small incentive, small percentage of whatever that extra income that was coming in. See the power of incentive. I mean, it's a small incentive. The second thing that dramatically transformed was that they had money to repair equipment. I mean, they were not working because the equipment was not working. The cath lab was not working. So the very fact that they were able to just repair their equipment, the motivation of the professionals in the government hospitals was tremendous. So this is to entice the public hospitals why there is an extra value proposition for the public hospitals. Otherwise, there is already budget. Why should I work? I mean, why this extra work of claiming and other things? So this is from a public hospital engagement perspective. But more importantly, I think most challenges in the private provider engagement perspective. As I mentioned, as a private provider, I mean, I think it's not just like a client relationship, it is a partnership. If that principle of partnership is brought in engaging the private sector, that means if there is openness to understand each other, the private sector should understand that there is a social responsibility to the private sector. So they cannot equate the cost and the profit motto of the private sector business with the social objective of the public sector. It's a taxpayer money being judiciously spent for the poorest patients. So this understanding has to come from the private provider. But at the same time, the payer has to understand the dynamics of the private providers. Because we cannot equate private providers as one entity. There are three entities. There is a corporate provider where the private equity controls the management. There is doctor-owned provider where the doctors establish it for their professional freedom, not for profit. But what the challenge they face is the cash flows. If they don't receive the money for the services they rendered in time, they don't have that equity money of the private equity to service the working capital. So if this sensitization, as a payer, you are negotiating with the private provider, that I understand your pain, and that is why I think the green channel that was introduced in the UP was very successful. I mean, you advance 50% of the claim, while you take your own time to process the claim. But the very that 50% is required because you have to pay the vendors. You have already bought the medicines and you have to pay the vendors. So this is a simple understanding. I think that openness to understand each other, that empathy to understand the private, what are the challenges they have. The third example you have seen, the trust hospital. Okay, there the objective is social objective. But again, the trust hospitals, one of the challenges they do face is in terms of the cash flows, is in terms of the capital required to upgrade the facility or to go to the remotest place that is required. So whether the policy making can provide this comfort, especially not in the metro cities. I mean, where you need these private providers or the public providers is where they're underserved, in the towns and other things. So can there be a policy space? I mean, these are some of the iterative learnings that we are having in terms of what type of private provider interaction has to be there. So the three things are there. I mean, one is the package financially viable? Not forget about profitable. As a provider, I mean, what we used to look at it is what is the mix? What is the percentage of free patients? What is the percentage publicly funded patients? What are the percentage private insurance patients? And what are the percentage better paying patients like CGHS? So we look at as the average revenue per discharge. And this average revenue per discharge is slightly exceeding the average cost per discharge, that means we say it is financially viable. For a corporate hospital, it cannot be viable because of their per capita investment per bed. I mean, they invest 1 crore per bed, whereas we invested 10 lakhs per bed. Naturally, your cost of capital is much higher. The private equity cost of capital is 24%. It is not 5% or 6%. So these are some of the factors I think we need to understand from a position of what makes private provider enthused to actually come forward to the provider. These are small things. One is the financial viability. The second is in-time payment, or at least the part payment, while it is being addressed. The third thing in the district hospitals or the sub-center levels, one of the critical thing is the professionals, and able to attract the professionals. And the third thing which we undermine is the threat of physical violence in some of these underserved areas for any emergency that something happens. So what policy decisions can strengthen that area in terms of providing the security to the providers? These are 3-4 areas I think if they're understood from both perspectives, the providers, I think there is, and we are experiencing, I think from a development partner perspective, from an iterative research perspective, there is a huge enthusiasm once they understood and you clarified some of their concerns, you addressed some of this, at least you attempted to meet midway that what is possible. And you enable them, suppose you want a quality, you support them to go through that quality assurance process. Similarly, you want to adopt ABDM. you just handhold them. I mean, whatever support that is required. So I think there is a requirement for that mindset change of engaging. I'm sure there will be much more enthusiasm from the private providers. Thank you.
Thank you, Dr. Reddy. I mean, I think it took me down to basics, you know. Whenever we used to talk about partnerships, and I think it's all about partnerships, it could be public-public, public-private, private-private. Whenever we are talking about partnerships, what is very important is that all partners can address the other partners, what's in it for me. So what is it that the other partner wants? That is what we need to understand in the true sense, without a bias, without a lens. And I think that is what Dr. Reddy alluded very beautifully in his remarks. I mean, obviously you were very academic when we were like sharing with us the difference between strategic and selective purchasing. I never looked at it that way, so that's a beautiful perspective of looking at it. I mean, it's a very interesting thing, and I'm sure we would like to delve deeper into that. But I think this very basic need for making any partnership work, I think that's what came out very beautifully in your remarks. So I think he deserves a big round of applause from all of us, please. I mean, I think we all clearly understood that the speakers were very passionate, and we went a little over time. So we were initially planning to do 2 rounds of questions, but I think the learning from 1 round of question has been enough for a few months. We can take it forward, the beautiful learnings which came away. Just to quickly summarize before I hand it back to the chair. So we saw how a small tweak in the administrative mechanisms and in the administrative structures can bring about really beautiful clinical improvements. From there we went into Dr. Minocher's comments, where we saw that how passion in your service delivery can really ensure that your services are used. So, going out, meeting the beneficiary, understanding them, and, catering to those needs. Then we came out and we saw that leadership is required at every level. So we should not always connote leadership with senior positions. I think leadership is something which goes down right to grassroots. And also the capacity building and the lack of management capacities in our public and private healthcare system. And then of course we got down to real basics with Dr. Reddy, where we were talking about addressing these needs of partnership. So I think it was a beautiful session. I think all our speakers deserve a big round of applause from all of us, please. And ma'am, yes, sure. I mean, do we have the time? Maybe we'll make one exception for you, Doctor. If you would. Chair, would you allow, ma'am? Would you prefer? We can have a few questions.
My question is to Mr. Minocher. I know I was really so delighted to see the way you had actually given training to the stakeholders, how to the users, the beneficiaries. But maybe in a state of Gujarat where actually have developed so much, and maybe the population also was limited to the tribal areas. But I am speaking actually in the state of Bihar. I am actually from AIIMS Patna, the director of AIIMS Patna, where I see actually the beneficiaries, they do not know actually. I do not know how through a government setup a similar kind of your model can be adopted, and a training can be a kind of training can be given, maybe through the what you said, your health officer training, those who give I do not know how that can be done through the government setup, so that the beneficiaries in a state where education is less, socioeconomic status is less, they can also get the benefit. They first understand actually how they can avail it.
Sure.
Yeah.
I'll answer that question. I'm very happy to inform you that SHA Gujarat is already doing this, what you're suggesting. I have learned that they have appointed people in public sector hospitals, Ayushman Bharat, to look after Ayushman Bharat patients. They go and meet the patients, make sure they are comfortable, check with them whether everything is okay or not. So they are doing exactly what we have been doing. We are doing it at both the OPD level and the IPD level. And I'm sure the government or the SHA is doing it already at the IPD level. So I think if I'm not mistaken, they have subcontracted this work to a third party And this is going on very well, as I understand. So does it answer your question, sir? So that is a private enterprise, yeah, subcontracted to them.
I got it, thank you.
Thank you.
My question is addressed to Randeep, sir, if I may, sir. Actually, my question springs from the last session that we had yesterday on best practices of states also. And that there's one point that has been irking me for a very long time. I'm CEO SHA for UP. And I would just begin by saying that, sir, it makes sense for a Karnataka or a Kerala or even a Tamil Nadu to push public hospitals and to try for their upgradation and to do a gatekeeping for them, to reserve certain packages for them. But in states like UP and Bihar, where the public infrastructure is not so strong, and when yesterday we heard the DG say that public infrastructure suffers from a lack of personnel and infrastructure, how fair is it to, I feel there is a skewed turn towards the public sector per se. And I think the spirit of IIHMR essentially was that the person who is a beneficiary will have the authority and the right to go to a private or a public sector hospital through his own choice. So how fair is it for us to just upgrade and push upon the public sector and to sort of try and not involve the private sector so much? Because I'm proud to say, ma'am, that we have 3,600 plus hospitals empaneled in UP and 2,500 plus are from the private sector. And to say that the private sector does not want to come on board because the HBP rates are not positive or there is a less of engagement, I would not want to say that, because we have hospitals that are 1,000 bedded, we have private medical colleges empaneled with us, we have Apollo Medics empaneled with us. So even corporate hospitals are coming on board and they are happy for like the Green Initiative, Green Channel Initiative that Dr. Reddy talked about. So I think engagement more with the private hospital is the key, because public infrastructure is a limited enterprise. We cannot go on expanding it to a very long time. And I think we are somewhere moving towards a paucity of trust maybe. So is there a change in dimension? Is there a course correction that we need to make? Or is what we said yesterday and today, is that the right way to do it? I just wanted to understand.
Yeah, thank you. It's a fairly long question, so my answer will be short. I think what suits you best needs to be done. ABPMJY has not said that path A or path B is necessarily good. We do appreciate that in UP, you need to take support of private hospitals more. We have not shut doors to private hospitals in Karnataka. If probably I came out that way, I stand corrected. What I said is the term which Dr. Reddy so prominently used is a strategic buying of services, where we feel that the public has to go to private hospitals, where we ourselves are not good enough to provide that service. By all means, that facility is available. But let me also inform you that prior to Ayushman Bharat, and there are hundreds of patients even walking into government hospitals in Karnataka, despite the scheme. The people who land up without a card, the people who get, and they have the benefit of government medical colleges in Karnataka. We have a lot of autonomous institutions like NIMANS and other such. We have cardiology institutes. So probably Karnataka has that advantage where we can go this way of ring fencing, of strategic buying of services, which other states may not. So I do appreciate where you're coming from, and we have also been asked this question from NHA, that why ring fencing, why protection of services, and it is a path that Karnataka has taken fairly early, and I said the scheme predates ABPMJY, which means we had our own state scheme and along came the national scheme which we merged with. So somewhere down the line we are looking at relaxations of certain procedures, levels of referral. As I said about emergency procedures, which Dr. Reddy was again mentioning about, those are completely exempt. You can kind of walk. And the referrals are given at probably within 10 minutes once we realize that facility is not available there. And it is not that one needs to skim through all the public health facilities. In that district, at that facility level, if that service is not available, immediately you are given a referral to go to a private hospital. So it's not such a watertight system. And I said somewhere down the line there could be a policy change, but not today. Thanks.
think we are learning really.
Thank you very much, sir. I'm Dr. Manorama Bakshi. I have been into public health for almost 2 decades, more than 2 decades, working with NACO, Ministry of Health and Family Welfare, and then with Tata Trust, and currently I am into a healthcare consultancy director. So my question is, as per Niti Aayog report, only 3 to 4% of the PPP models are adopted in health segment, whereas if we see the transport segment, it is more than 45 to 50%. While as we have been propagating PPP since almost more than 2 decades, I start right from when I was with UNDP doing HIV/AIDS mainstreaming. My question to you is, sir, sometimes like I have seen, since I have been into consultancy, like people approach us, corporate supporters, कि आप कर दीजिएगा, government का जितना भी advocacy है आप कर दीजिएगा, because it's very difficult for us to crack the, the kind of circle. And while we are propagating, like Make in India, we are propagating that, but some of things are not coming up. When it comes to the public-private partnerships, there are a lot of hiccups. So my suggestion and request is, sir, how we can make it very easy, how we can have SOPs at each and every level, कि इस level पे इतना दिन तक करना चाहिए. That's my submission to you, sir. Thank you.
I would rather call it as a recommendation than a question, to be honest with you. I think it's an interesting recommendation, and I think we can learn from other sectors. If any of the panelists would like to, Sandeep, would you like to?
No, we have do have PPP run institutions in Karnataka. In fact, one of the prominent district hospitals in the state has a fair tie-up with a private hospital partner, and mostly in the tertiary sector, the district level hospitals, I would see we should be more open to PPP. Definitely not in terms of giving it up lock, stock and barrel, but in terms of where something can be administered better, something can be delivered better on the ground, we have done it. In fact, our dialysis services, if you look at Karnataka's dialysis services, we have not aligned with the ABPMJY scheme. We said we'll run it on PPP basis. So the state runs a very robust dialysis scheme away from the ABPMJY, and we've seen a fair amount of success in that. Now we need to see what other facilities can be run in this manner, especially in the tertiary, probably a cancer care or cardiology services, which may need some element of specialization and better administration.
I just want to add and address both this and the previous question also. That again, it comes to the question of the clientele and the services that we are providing. Again, what Dr. Reddy said, what saying about the kind of services that we need to provide. Actually, what Randeep has said, and what in Karnataka, the model they're following of going to the public health facility first for your basic requirements. It's a question of about how, to what extent a facility can provide which services and how it is best, how its services, its presence is best utilized. Now, for instance, in AIMS, Delhi, you'll see people queuing up in the footpaths from 3 in the morning, and probably a huge number of them would be for very basic, simple services, which even a sub-center could perhaps address, maybe a case of diarrhea or something like that. So we need to look at when we see healthcare, and I think healthcare and education in a state, in a country like ours, government cannot divest itself of its responsibility to providing public healthcare services at the basic level, and at the tertiary level, maybe to an extent at secondary level also, but to tertiary level, there can definitely be the PPP model that you're looking at under the PMJY, and I can tell you even about the Pradhan Mantri dialysis program, where already there also, in many states, we are having a PPP model, one nation, one dialysis, anywhere, you can You can be registered on the portal, you can avail of these services, whichever hospital where this service, where the PPP model is there, or from the government health facility. So it is something we need to look at it from many points of view, the user, the client, and then the ability in which, so that both can grow, and we need to find our own spaces where we can grow, and that will be the optimum use of our specialists, and then our general medical doctors, and the other community health, public health specialists that we have, all the, and not to speak of not to leave out the nursing staff that we have. So everywhere, everyone, we need to have a better and optimal utilization. Thank you.
Thank you so much, ma'am. With your permission, ma'am, we can now conclude the session.
Yes,
because I think
running out of time, really.
we are also getting late for the next session, which most probably will be graced by the minister. So we look forward to that. And thank you. I would like to thank the chair and the panelists. We will just have a quick round of applause for you.
Before we end the session, we would like to distribute the mementos. Thank you, everybody. I would like to request our moderator, Mr. Amit Paliwal, to hand out the memento to our chair for today's session. I would also request the moderator to hand out the mementos to the panelists, starting with Mr. Randeep D, Dr. Krishna Reddy, Mr. Aspi Minocher, and Dr. P.R. Sodhani. I would also request the chair to present the memento to Mr. Amit Paliwal. Thank you so much, everyone. Please go down to the plenary hall for the last session for today.